Okay, this is Dan Reinstein. I am going to lecture now on detection of keratoconus, but with the addition of a new parameter, a new tool that has been introduced over the last 10 years, and that is the epithelial thickness map. Traditionally, keratoconus was diagnosed by clinical signs, Monson sign, severe deformity of the cornea. So while corneal topography was introduced in the mid-80s, it was in the early 90s that it really came into common clinical usage because we were trying to exclude keratoconic corneas from having corneal refractive surgery. So in the early 90s, mid-90s, when I go through our keratoconus screening protocols that we used to use, we had basically 13 factors that we would weigh up in our minds to either increase or decrease the clinical suspicion of keratoconus in a case. And it wasn't just the topography, it was whether the patient had against the rule or oblique astigmatism, whether there was a high degree of astigmatism, whether the corneal thickness was on the thin side, whether there was, because obviously we weren't measuring corneal thickness in 3D, remember this was handheld pachymetry, this was one-point pachymetry, whether there was reduced corrected distance visual acuity, whether the contrast sensitivity was reduced for what you'd expect for their age, whether there was a family history of keratoconus, even though only 4% of keratoconus runs in families, and of course a history of refractive instability, particularly if there was increasing cylinder over the years or shifting or rotation of the axis of the cylinder. Obviously younger patients increased your suspicion, whether there was right eye versus left eye asymmetry in the amount of astigmatism or the orientation of the astigmatism, or there was asymmetry in the thickness or the keratometry or the refraction. Ethnicity, of course, was something that raised suspicion of keratoconus. We know that keratoconus is much more common in certain ethnic groups. History of eye rubbing, atopy, allergies, this raised suspicion of keratoconus. Just whether the keratometry itself was steep or not was the earliest factor. In fact, Barraquer, in his 1980 textbook, described to avoid ectasia, keratolysis should not be done in corneas that are steeper than 47 diopters. So this was the earliest keratoconus screening parameter, it seems. That would have been during the 40s and 50s. And lastly, of course, inferior steepening and asymmetric bow ties, skew bow tie patterns from topography, which came in as topography became computerized. Now, in the mid-90s, a number of researchers, Kleiss, Wilson, Rabinowitz, they introduced computer-based machines that would analyze the topography and look at superior inferior differences and just topographic features that could be electronically analyzed in order to produce a probability of keratoconus. So a certain automation to the reading of the surface topography. By 97, the OrbScan 2, which was really the first commercially viable tomographer, actually TMS came up with the TMS, I forgot the name of it. They came out with a laser slit tomographer, but the price was prohibitive. It wasn't until 97 that the OrbScan 2 came out with a white light slit that scanned across the cornea, and they added a Placido system in front of it, which made the keratometry fairly accurate, actually. And now we were starting to use back surface shape. And when this started, of course, people were first looking at it qualitatively. The OrbScan itself devised a system of plotting the best fit sphere of the back surface so that the redder the vertex of the back surface, the greater the elevation from the vertex to the best fit sphere of the whole posterior surface. And people were trying to say that a best fit sphere elevation of more than X would be suggestive of keratoconus. We didn't really subscribe to that because the periphery of the cornea could severely affect what this index would be, and absolutely normal corneas could have very high elevation. We were looking more at qualitative factors, how eccentric this posterior surface was, whether it coincided with the thinnest part of the cornea, and whether that was eccentric or further away from the inferonasal position that one would expect it to be. And it wasn't until a couple of years later, in the late 90s, where I actually, when I was in my fellowship in Vancouver, that I scanned with the high-frequency ultrasound some keratoconic corneas, and we discovered this very characteristic pattern of thinning of the epithelium over the cone and a thickened ring around it, but we'll talk about that more later. And so it was in 2002 that I suggested that the epithelial thickness profile could be used as a form of screening for keratoconus. And we're going to discuss a lot about this in the rest of the lecture. Others were introducing wavefront parameters into screening. Of course, if there was more coma, that was suggestive of keratoconus. In the mid-2000s, the ocular response analyzer came out, and this was a way of analyzing the bounciness of the cornea, if you like, to a standardized puff. And it was a fancy puff tonometer, but it actually measured the excursion and incursion of the cornea over time, and therefore measured in a way, the biomechanical properties of, well, it was said the cornea, but it turns out it's, of course, the whole eye. And so it was thought that parameters coming out of this machine could tell us about softness of the cornea, and this could correlate to keratoconic screening. Finally, a second tomographic device came onto the market. It was first published in 2005 in a German journal, but of course everyone knows the Pentacam now. And this was again another white light source slit, which then allowed us to get back surface information. Ambrosio was very interested in the thickness progression and devised studies to do with the rate of change of thickness progression, either as a relative term or as an absolute amount of change. And then Belin, together with Ambrosio, they devised this Belin-Ambrosio display, the Belin concept being of isolating the posterior surface cone area, removing it from the best fit sphere, adding it back into the plot, a very powerful tool for detecting whether a back surface is abnormal. It was then in 2010, of course, OrbScan was used by Professor Gatinel in Paris to devise a automated analysis system of the front and back surface OrbScan data in order to try and screen for keratoconus. This is called the SCORE analysis. And finally, in 2012, a commercially available epithelial thickness map came on the market internationally. This is wonderful. This means that many more investigators can now get into the properties of the epithelial thickness profile and how it behaves and how we can use this as a powerful tool for screening for keratoconus. So if we go to how we screen for keratoconus now, we have added, of course, a number of machine-based parameters or even automatic analysis factors that give us a better way of alerting us to the presence of keratoconus at the earliest stages. Because obviously the key here, keratoconus is obvious if it's obvious, but what we're trying to do here is to diagnose it as early as possible, before the obvious signs appear. And when the signs are mild, then you start overlapping into the normal topography or tomography or epithelial thickness profile elements, and that's where we're concentrating our efforts on, because these are the people who can slip through a screening system, end up with surgery, and obviously with an accelerated ectatic process. Back in the day, of course, 10 years ago, it's worth mentioning, before we had cross-linking, so this is up until the mid-2000s, keratoconus progression, or the acceleration of keratoconus progression by refractive surgery, otherwise known as keratectasia, iatrogenic, was a horrible diagnosis, because this also coincided with the relatively primitive way that corneal surgeons dealt with ectasia, which was full penetrating corneal transplant, which was a very severe milestone for an eye in terms of the life of that eye. Of course, once keratoconus could be halted, or at least the progression arrested by cross-linking, this has now become a much less serious complication of corneal refractive surgery. So let's just go into now epithelial thickness measurement and how this is going to help us. But first, let's go through some of the theory. In the 90s, of course, at Cornell University, I developed a system with my co-workers, Ron Silverman and Jack Coleman, Jack Coleman's lab, where we could scan the whole cornea, basically, 10 millimeters worth of cornea, and we can get individual interfaces that would show up, the front surface, Bowman's, and let's say a LASIK interface, and we could make measurements between these interfaces with 1 micron precision. And because we could scan in 3D multimeridionally, we were able to make maps of each of these layers. And these are early scans showing a pre and post LASIK. You can see a tiny little step in the bed indicated by the arrow. You can see that the flap was not fully distended to the periphery. You can see a small gap here where potential for epithelial ingrowth, or if the flap is not fully distended, perhaps in the induction of cylinder. We were starting to really look at the microanatomy of LASIK and try and correlate this to how this will affect clinical outcomes. We demonstrated that using the analytic signal magnitude, we could increase the signal-to-noise ratio of this high-frequency ultrasound so much that we could detect each surface within the cornea to less than 1 micron localization precision, 0.87 micron localization precision. And this is a system that we developed in the early 90s. In 2000, I published the first 12-map, C12 as we call it, 12-map analysis of the LASIK procedure. And the way this map works is the first column shows the preoperative epithelial thickness, the stromal thickness, and the corneal thickness map. The second column would be the postoperative epithelial thickness, stromal thickness, and full corneal thickness. The rest of the maps would be derived. So for example, the epithelial change map would be derived by subtracting the post-op from the pre-op. The stromal change map would be derived by subtracting the pre-op from the post-op, so that the ablation or the tissue removal would be a positive number. This map was interesting because we discovered that in the periphery of the cornea, the stroma became thicker than pre-op. We could, of course, now measure in 3 dimensions the residual stromal thickness map. And this enabled us to find the thinnest point on the residual stromal thickness, which was important because flaps in the microkeratome days were not even. And you could have zones of the flap that were very, very thick. And so the thinnest residual stromal thickness after surgery might well not have been in the center of the cornea. We were able to map, of course, the full flap, including the epithelial changes. But of course, that is not a way of knowing how well your microkeratome is working or your flap creation device. The only way of devising what the actual flap was that was cut by your device was to add the pre-op epithelium to the stromal component of the flap, say 3 months after surgery, after all the edema had subsided. And by adding those 2 elements in time displaced, we could derive what the original full flap that was cut by the device would be. So on to epithelium. Here, just for comparison, here is a high-frequency ultrasound scan on the left and a prototype 9mm map from the RT view. And we can see that the values are fairly similar. You can see that the raw data from the ultrasound and from the OCT just below here, obviously to scale because the OCT is only taking data from the 9mm zone. We have data from the essentially almost 10 millimeters. But you can see that the resolution of the ultrasound and the OCT are quite good for preoperative corneas. Post-op, it's slightly different. You can see here's a post-hyperopic ablation, and you can see that the trough of hyperopic ablation has been filled by thickening of epithelium. And it's demonstrated both on the OCT as well as the ultrasound map. But you can see on the OCT, certainly centrally, it's very difficult to distinguish the flap interface, whereas on the ultrasound image, if you look nice and close, you can see that the flap interface is very clearly delineated for us, separate from Bowman's and obviously the front surface of the cornea. That's quite easy to see on the expanded raw data images. To compare what we get from high-frequency ultrasound or OCT, and we've published a study now just comparing the absolute values obtained from either virgin corneas or post-LASIK corneas with both ultrasound or OCT. And what we found was that the OCT tends to measure thinner than ultrasound, but it measures a lot more thinner in the infranasal region of virgin corneas. That's on the left here. And we found that post-LASIK, the OCT measured even less thick than on virgin cornea. So there's something that's changing with respect to the cornea after surgery, and it could all be to do with refractive index changes, or it could be to do with the fact that the tear film, of course the tear film is included in the OCT measurement. Possibly the tear film is thinner after LASIK than it is on a virgin cornea. In any case, these measurements are close between the two devices, but they're not 100% interchangeable. So if we now go to understand what is the normal thickness profile of the human cornea, the first publication ever to show this in vivo was our paper in 2008 in the Journal of Refractive Surgery, where we demonstrated for a series of 55 patients, that's obviously 110 eyes, 55 right eyes, 55 left eyes, and we averaged the thickness profile and found that the mean thickness for this population was very similar to what we'd published 15 years before. Mean thickness was 53.5 microns. There was about a 6 micron superior to inferior difference, and there was about a 1 micron nasal to temporal difference for right and left eyes, which had a mirrored pattern. How to explain this? Well, quite easily. The epithelial thickness profile responds to the shape and tension and rigidity of the lid, and of course we blink 10,000 times a day, and the tarsus is a semi-rigid plate which has shape, and the blinking action of course is a mechanical force, and this takes place about 10,000 times a day while we're awake. While we're asleep, the eyelid is closed, so the template is overlying the corneal surface, and it shapes the epithelium. If we think of the epithelium as coming in from the periphery and then growing out from the basal cells to wing cells to scuffing off the surface, this eyelid motion during the day provides an inward force, and we have the outward growth force, and according to just like Newton's third law, if there's an equal and opposite force, the epithelium will therefore be stable, and of course the epithelium is stable. If the epithelium wasn't stable, then glasses wouldn't work. This is the marvel of the stability of refraction, is that we have a layer called the epithelium which turns over once a week. Every 7 days the layer turns over, and yet the curvature of the outer surface of the cornea is maintained to within less than 0.1 millimeters, so that your glasses at 9 a.m. in the morning on Monday are exactly the same as they would need to be at 2 o'clock in the morning on Friday night at a nightclub. So this is the wonder of the epithelium, is that it maintains absolute stability despite the fact that it's turning over. And there's only one way that can be, and that is if the forces of growth and forces of retention of the shape are equal and opposite. So this goes to slightly explain why it is that the keratoconic cornea has a particular epithelial thickness pattern. And as I said earlier, the epithelium thins over the cone and it thickens around the cone. You can see on the B scans above here that as the severity of the keratoconus increases, so the thinnest point of the epithelium gets thinner. Of course, also the thickest portion of the surrounding ring gets thicker. We therefore thought we could try and exploit this difference in order to see whether at the extremes the earliest extremes, we might be able to pick up changes in the epithelium that would prove to be more sensitive than changes in either the front or even the back surface. So just head on, looking at our keratoconic study, we found quite different indices for thickest, thinnest, and the difference between thickest and thinnest points. However, of course, these were actual keratoconic eyes versus normal, but you can see the patterns are quite different. Within a very short time of the OCT epithelial maps from RTView becoming commercially available, David Huang, who obviously is the father of OCT, investigated keratoconics versus normals as we had, and did find the same patterns, that there was thinning around the cone and thickening around the cone. Of course, this machine was only measuring in the 6 millimeter zone, so they weren't able to see the full donut shape. But other groups, such as Laurent Laroche's group at Hôpital de Gainsvin in Paris, they also looked at epithelial thickness profiles and confirmed our previous published work showing that the epithelium becomes thinner over the steeper part of the cones. But what was interesting about their work was that they also demonstrated in line with what we had described about epithelial behavior for 20 years, that the epithelium responds to the rate of change of curvature of the stromal surface. So in very advanced keratoconus, where there's been marked stromal loss, so the epithelium becomes thicker over the cone, because the rate of change of curvature is now such that the epithelium is now filling a trough as opposed to thinning over a peak. And if you just look at these B scans, these OCTs, it's absolutely exquisite to see how the process of nature, the way that the epithelium is designed to behave, to restore the stromal surface curvature despite major alterations in the optics of the stromal surface alone. So it's really quite beautiful. So the theory of early keratoconic screening using epithelial maps is illustrated in these line drawings. So if we think of a normal cornea with a corneal front surface in red, stromal surface in purple, and a back surface in yellow, of course the epithelium is between the front and bowman surface. In early keratoconus, or at least in keratoconus, we're going to get inferior bulging, thinning of the cornea, and of course the epithelium is going to thin over that cone and thicken around the cone. But at an earlier stage, the stromal change is going to occur to a degree that is masked by the epithelium. So the epithelium is able to absorb all of the anterior stromal surface change. And therefore the stromal surface topography is masked by placido anterior surface topography or any other anterior surface topography. And therefore only the back surface would indicate whether there was a keratoconic process going on. And if you like, the bonus point of measuring epithelium in all your patients pre-op is that you can have corneas that have inferior steepening on topography, but they do not have keratoconus, and you can prove that they don't have keratoconus by looking at the epithelial thickness profile, because if the epithelium is thicker over the region of the inferior steepening, then by definition this cannot be keratoconus. And we're going to talk about that a bit later as well. So let's look at 3 examples in our index publication that we published in the Journal of Refractive Surgery, where the diagnosis provided by the automatic machine for case 1 was normal, case 2 was a keratoconic pattern, and case 3 normal. So we're looking at these individually. Case 1 is a 25-year-old male with normal keratometry, very little cylinder, although slightly oblique. Of course, there was asymmetry in the bow tie pattern, but the best corrected visual acuity was 2016, and the automated algorithm determined that this was essentially a normal cornea. However, when we look at the epithelial thickness profile, we see the classic keratoconic epithelial pattern. We see thinning over the region where the back surface apex was elevated and eccentric, and we see thickening in a donut pattern around that thinner point. So here is a case where most people would have considered this cornea to be normal, other than being extremely sensitive to bow tie asymmetry. And here we were changing the diagnosis to keratoconus. Case 2, the machine diagnosis would prevent anyone from doing corneal refractive surgery on this cornea in those days. And the wavefront, of course, showed high coma, again supportive of keratoconus. The keratometry was a little bit steeper than average, but not steep. The best corrected visual acuity was 2016, and it was a 46-year-old patient. The orb scan showed the inferior steepening as well, but in this case, the epithelial map showed thickening over the steeper parts, and therefore there was no question that this is not a keratoconic cornea. There's no way this could be a keratoconic cornea. And so the diagnosis was switched from subclinical keratoconus to a normal cornea. This patient actually received LASIK, and I'll explain later in a study how we followed this. Case 3 was a cornea that no anterior surface topographer would ever suggest was keratoconic, and even looking at the back surface information, yes, the cornea is probably slightly on the thinner side of normal, but still normal. Even the Bellin-Ambrosio parameters for corneal thickness progression and the back surface plot, totally normal for this cornea. But when we look at the back surface elevation, which was eccentric, and we look at it in the context of the epithelial thickness profile, there we are. We have thinning over the back surface elevation, which is eccentric, and we have a thickening in a ring pattern around the steeper posterior apex. So in this case, we had to determine that this was keratoconus was a possible diagnosis in this case, and so this patient was denied surgery based on this fact. So we see that for each of these three cases, the final diagnosis, including epithelial thickness profile, was reversed by using epithelial thickness data. Here's another example where the topography looked quite abnormal. Certainly the Bell and Ambrosio would make this look like a barn door keratoconic eye. Absolutely keratoconic, even though you can see that the corneal thickness was quite high, but the parameters of thickness progression, the D, the back surface plot, the Balin plot, totally characteristic of keratoconus, orb scan as well, and very, very high coma, and yet the epithelial thickness profile was absolutely normal and demonstrated that this was in fact a normal cornea. If we look at the B scan section here, by ultrasound you can see that that thickening of epithelium is not because of severe keratoconus. So the Bell and Ambrosio would suggest severe keratoconus, but the cross-sectional B scan shows you that it's not a case of severe keratoconus with tissue loss and therefore epithelial thickening over the cone. So it's a beautiful example. And here's another one where, again, if, for example, you look at the anterior surface topography, if this case had been done by LASIK and it had developed ectasia, and a court case took place and the expert for the plaintiff showed this left-hand topography and said, this case should never have been done because this was clearly keratoconus from the asymmetric pattern, the defense would then say, well, the thing is that when you look at the epithelial maps, this steepening found on topography was entirely explained by thicker epithelium. There is no way there could have been a subsurface cone with thicker epithelium over this region, and therefore there was no way of determining why this cornea was going to become ectatic. Certainly not from a pre-existing keratoconus. So this theory of using epithelial thickness profiles was tested, and we performed a study in which we had screened 1,500 consecutive myopic eyes by Atlas and OrbScan 2 tomography. Of these 1,500 eyes, 9% of them were found to be suspicious, and that's about the rate that we were getting in the late 90s, early 2000s when we were screening with these devices. These 9% of patients underwent epithelial thickness mapping. The epithelial thickness mapping resulted in us diagnosing true keratoconus in 16% of the equivocal cases, but 84% of the equivocal cases came out as being non-keratoconic. Of these cases, of these 114 eyes, we were able to do LASIK in 90 of them. We had to do PRK in 24 of these eyes simply because of corneal thickness constraints and residual stromal thickness calculations. So not because we were hedging our bets, as some have suggested to do, but rather just because they couldn't have LASIK. So the eyes that we could do LASIK in, this was 90 eyes, all of these eyes received LASIK. And then what we did was to grab a LASIK control group from our database so that we have a case control study where we matched for spherical equivalent and cylinder and intraocular pressure and age. And what we found was that the stability of the refraction up to a year post-LASIK was identical between the suspect keratoconic group and the LASIK control group that were not suspect. If we look at each time points, there was no difference statistically in the refractive regression that's observed from day 1 to 12 months. So these two groups behaved exactly the same. There was no difference in safety between the two groups. And a vector analysis showed that there was no difference within groups from the 3-month to the 12-month visit in terms of change of cylinder. There was no difference between groups at the 3 months or at the 12 months in terms of amount of cylinder present, and the vector stability, the change in cylinder between 3 and 12 months was identical between the two groups. So what we showed was that you can't judge the book by its cover. You have to read the first chapter, and that's the epithelium. And the first chapter tells you a lot. Here are 6 maps of corneas that are obviously normal and determined to be normal by the algorithm, which, however, on epithelial thickness mapping demonstrated subsurface stromal cones. And you have the classic pattern of thinning of the epithelium with thickening of the epithelium around it, donut pattern. None of these cases in my practice received corneal refractive surgery, and I could say these are those cases where I avoided producing ectasia, and of course ectasia which would have been called ectasia without a cause by anyone who had not seen epithelial thickness maps. On the other hand, I have here 7 maps, these are just 7 examples of the many, which were diagnosed by the machine as being suspect keratoconus. Now whether we agree with the machine or not, it would be a rather brave surgeon to take an atlas map such as this, no matter how normal it looks, how not asymmetric it looks, with a label in red on the machine that says suspect keratoconus, and this is printed in the medical record, and then go and do LASIK with a handcetome, with a microkeratome. It would take a lot of guts. But you see, you don't need guts if you have an epithelial thickness profile, because in each of these cases we can prove that there was no keratoconus, because the epithelial thickness profile proves that there, over the area of steepening, there isn't thinning or focal thinning of the epithelium, and these are all normal corneas, and all of these were the kinds of cases that underwent LASIK in our stability study. Now in recent years we applied for and got an NIH grant through Columbia University with my erstwhile colleague in this area of ultrasound scanning, Ron Silverman, and his lab. We basically went through and picked out something like 180 parameters that we thought could possibly have something to do with epithelial profiles heralding early keratoconus. And we popped all of these into a regression model. Well, less than 10 of these parameters survived in the model, but this model was able to very nicely categorize keratoconus according to the grading system which we accept, like the Krumeich classification. Very nice discriminant analysis performed just by looking at the epithelial thickness profile alone. And in fact, we got complete separation between normal and keratoconic eyes using just the epithelium, not the topography, not the posterior surface. Now, Laroche's group in Paris tried to use, let's say, one of the parameters of epithelial thickness, say the minimum thickness, to see how well just looking at the minimum thickness of the epithelial thickness profile, whether this would separate normals from keratoconics. And of course, it's not a very sensitive measure, as you can see from the ROC curve. We'll look at other groups, David Huang's group, that also demonstrated that the minimum thickness is not a good discriminant between normals and keratoconus, but they did find that the pattern standard deviation did provide a fairly good separation between normal and keratoconics. Of course, we're not particularly interested in being able to separate normals from keratoconics because we've diagnosed the keratoconics, and so it's a circular argument. What we're interested in is being able to distinguish eyes that are not obviously keratoconic. So as we can see, the evolution of keratoconus screening has gone from just clinical signs with retinoscopy to including front surface automated computerized analysis. We've been able to detect even more keratoconus earlier by adding the back surface information. And now by adding epithelial thickness profiles, we're able to get even further in detecting keratoconus even earlier than just back surface and anterior surface tomography alone.